but I think this is also relevant just for people with medical complexity. Another way of stating that would be like older physiologic age. Um, I, of course, have no disclosures and admit that I chose this topic because I think individualized screening and chronic medical therapies, it's an area that I've struggled with to find guidance on, and it's I think something we wrestle with on a fairly frequent basis. So the objectives for this are to review how life expectancy can impact treatment and screening and decisions in consideration of time lag to benefit. Review the potential harms of continued screening in older adults. I think we have some degree of familiarity with that, but it's worth reviewing those things again. And then identify some, what I would argue are underutilized prognostic tools to see how they can aid us in making more informed and evidence-based individualized decisions, medical decisions, and discuss some strategies to aid in patient communication regarding screening and prognosis. Okay. So I think the relevance to the to us at large, I mean, it should be fairly obvious, but I think first of all, every care decision that we make has a timeline to benefit, and we need to be conscious of that. And life expectancy and functional status can really vary widely once we're dealing with people who have aged into this zone of more individualized decision making, kind of beyond the guidelines. And so there's no practical way for population-wide guidelines to be written for people in this territory. And so we really do have to develop some competency with this. And this is something that we're bad at. I mean, prognostication, we're going to talk about this a little bit more, but in general, doctors have a bad track record with this, and when left to their own devices. And this leads to harm. We end up over screening and over treating people, and then in some cases under screening and under treating some people, and I think this would be one thing if it was like a lipoprotein A talk where it's like, here's a bad thing and what can we do about it, really just know that it exists. But like this is something that we can do better with, because there have been recent development of tools, evidence-based tools to help with this. And most importantly, our patients have a vested interest in this. From our studies, like in surveys and talking to patients, we know that this impacts their decision making about the rest of their lives. And when they have prognostic information, and I think it's an uncomfortable topic, but more often than not, the evidence points to people wanting to know. And I think this also allows us to move out of a zone of like paternalism and making decisions on behalf of patients, and saying, okay, we're going to stop your colonoscopy screenings now, and starting to move into the zone of shared decision making, which is really ideal for any major medical decision. And then additionally, I think that this can help us with regards to making decisions that involve other specialties. I don't think that the prognostication is something that's limited to primary care. Obviously, this matters for cardiologists, whether they're going to put an ICD in somebody, or with oncologists with regards to aggressive chemo regimens and so on. And I just touching on definition here broadly, that prognosis is intended to estimate likelihood of an outcome due to a health condition. This can be very general. I think it's just that I'm just trying to step back from, I think, our bias of thinking about prognosis as being something specific to the usage of cancer and morbidity, mortality related to that. So, but yeah, it can be targeted toward life expectancy, functional status changes. So this is like one of those screenshotable tables that can be, and this is kind of a summary of some of the potential evidence-based prognostic decisions and cutoffs for like lag time to benefit for common medical decisions, and some of these things exist in the zone of what we would traditionally consider hospice or palliative care, and included in this is, of course, discussion of the fact that a referral to hospice, appropriately identifying when that should happen, is something that that is its own medical decision. But there's also, things like looking at the timeline for microvascular complications with diabetes. Are we needlessly being too aggressive with people's glycemic control? Some things on this table are going to vary based on the evidence that you're reviewing. There might be the primary tool that I'm going to advocate that people utilize, the eprognosis.org, has some variances from this table, which is taken from various sources. But besides this table, other things, considerations, care decisions that could be impacted would be like if somebody's on, chronic methadone therapy, like when to stop QTC monitoring, or in consideration of stopping anticoagulant therapy for patients with AFib, or deactivating an ICD. So, and the decisions don't stop there. But getting into this framework of thinking can help. Okay. So let's talk about how bad we are at making predictions about how long people are going to live. So the first thing that I'd highlight is that the prognosis is a diminishing component of medical education curriculum. There's a whole separate paper on this that's interesting. It basically talks about how, basically in the textbook, like prognosis is now being boiled down to like a few sentences. And I think there's a lot of different reasons for this, but one of the things is that I think that the core clinical management of what it meant to be a doctor a long time ago was sometimes to be somebody who just like stands vigil and recognizes and it has knowledge of the natural history of a course of disease and provides counseling to a family or a patient about when they might pass or what's going to happen to them. And I think for multiple reasons, that's become, in part because we've become much more intervention focused and with our increased capabilities. But yeah, I think it's maybe not sitting as squarely in the core of what we consider a core skill set. And I think the evidence points to clinicians consistently overestimating survival. And ironically, continuity with patients over the long term actually tends us to make us less accurate with prognosis, which is very disconcerting. So just to pull up some evidence on this. So this is a systemic review, prediction of survival and palliative care, based on clinician assessment, and included 42 studies working with adults in the palliative care setting, and excluded ICU and post-surgical patients. And essentially, if we look at, these, these are the percentage accurate estimates on how long people are going to live. So just in general, we can see how terrible. I mean, this one maybe a little bit better, but overall, not awesome. And I'm wondering, like, I've never seen like seen it within the culture of medicine, us doing M&Ms on discussing how we've missed the mark on prognostication. Doesn't seem like something that it seems like we try to just like uncertainty within a disease process. But I do wonder culturally, and this is me editorializing, is just that we've acquired a little bit of learned helplessness on this topic where we kind of, we don't do great with the prognostication, and then there may not be a lot of reexamination of that. And I think maybe there's a bias here about overvaluing our interventions, because the data supports that, again, that we overestimate people's survival pretty significantly. So these are in this review, these are the studies that we're underestimating, and then these are the ones that were clinicians overestimated. And we can see these are the specific, the differences in days, the actual survival versus predicted survival. Okay. So this is kind of a cursory look at our cancer screening guidelines and focusing on the relevance for older adults. These are not the complete guidelines as they stand, but I'm taking this as an opportunity to highlight where where in the guidelines, we are told to make a determination in part or in whole based on life expectancy. As you can see, and for like our 4 major cancer screenings, that it is boiled into the definition of all of these, and that's appropriate. It's just disconcerting that we are having to make these decisions, and I don't think as a whole have a great level of confidence in our ability to prognosticate. I think the reason why we end up in this position is that, like, cancer screening decisions past the age of 75 are complex. And most adults over 75, or most randomized controlled trials are not inclusive of people of that age group. I would point to most recently, like the big Nordic trial or colonoscopy trial, to look at the benefit of colonoscopy, and that all included adults up to age 64. So, yeah, so it's, so we don't always have the strongest evidence base to support decisions of benefit and harms in older adults. So the challenges with making these individualized decisions are pretty clear. And it leads us to this place where we overscreen older adults with limited life expectancy. We're underscreening older adults with longer life expectancy. In situations, we're doing harm. And prognosis and clinical statistics are both difficult and time-consuming topics to communicate with patients about. We sometimes end up in this ham-fisted position where we say something like, "Congratulations, you don't need any more mammograms," and there's there can be huge problems with just framing these screening study as just overtly negative or overtly positive. I had my aunt come home from a visit with her doctor, and and her physician had said something to that effect, and she's like, oh great, now my physician wants me to die. And 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 oftentimes these are the studies that people care the most about. They've personally might have experienced a death in the family from somebody close to them. Anyway, so there's a lot of harm and kind of a set it and forget it attitude toward the guidelines, and it's it can be challenging to make the time to individualize this and thoughtfully do shared decision making. It's one of the most routine things that we do that is exceedingly difficult to be thoughtful about. So let's just go through at least a little bit of a review of the potential harms. So for breast cancer screening, so on a whole, false positives do tend to decrease with screening in older women with age, and the biopsy results do tend to be more true positives, but we do end up with a significant number of still having false positives, and it's, you know, these can be terrifying for the women involved. It can be incredibly distressing for women going through a biopsy process if they have some degree of underlying dementia and confusion about the process. You know, it's just like some back of the napkin math, and this is like, if you know, based on some of these numbers for hypotheticals, like if we do you know, 240 screenings, might have 16 positive screens and 4 biopsies to produce 3 non-cancer diagnoses and catch 1 cancer. So that would be with talking about a number needed to screen of 240. Sorry, was there? Okay. Sorry, I thought I heard a noise.
Sorry, I coughed without mute on. Apologies.
Okay. Yeah. And we'll talk about, yeah, so colorectal cancer screening, we have potential harms screening, you know, for upwards of 23% false positive rates in 10 years of screening based on stool testing with fecal occult blood tests, you know, and then subsequent colonoscopies. It's common for people to have some manner of limited GI symptoms. PrEP can be onerous for patients. I've had people who, due to mobility issues, you know, and being in their early 80s, but still wanted to pursue a colonoscopy, they were needing admission to the hospital for, you know, assistance with bowel prep. Perforation rates are typically 1 per 1,000, and post polypectomy bleeding 3.6 in 1,000. Cardiopulmonary events are consideration, and yeah, and as we discussed before, the Nordic trial didn't provide much insight for people over the age of 65 because they weren't included in the study. Okay, for lung cancer screening, potential harms of screening. So for false positives with lung cancer screening are common, and these can result in, you know, need for surgical procedures and biopsies. And I think these numbers are pretty sobering. You know, so for the initial the national lung screening trial, you know, for 53,000 patients, we, you know, it did decrease risk of lung cancer mortality in the range of 20 to 24%. If you also look at the Nelson trial, that was the Scandinavian trial. But you know, in the National Lung Cancer Screening Trial, you know, for people, 39% of people had a false positive at some, or had a finding at some point, with 96% of those being false positives. So it you know, it does take thoughtful discussion, particularly with lung cancer screening, depending on people's comorbidities. Prostate cancer, and I would just say, is in the process of kind of the U.S. Preventative Task Force is, you know, working on updating some recommendations on this topic, because there is a rate of there is some rise in cases of metastatic prostate cancer, but false positives are very common, and prostate biopsies are not fun. People, you know, they can be very difficult for patients and uncomfortable, and you know, we end up with overdiagnosis of prostate cancer. That is to say, cancers that wouldn't otherwise have led to the patient's death, and this is oftentimes leading to interventions that that have significant impact on the patient's quality of life. So how can we, you know, prognosticate more effectively? There are, like, you know, specific disease calculators, scores that we can use. A lot of these are intended, you know, potentially for the acute setting, or like under a year in time. They you know, for people with severe end organ disease, they can be helpful. This is not comprehensive. I've just identified a few. But a lot of them, like, you know, what we're really looking for when we're looking at screening tests is kind of a comprehensive look at the patient with a non-disease specific calculator for people with chronic comorbidities, that in their, like, cumulative effect, plus like consideration of their functional status. And in the tools that are provided on this website, eprognosis.org, which is basically a repository of reasonably effective prognostic tools. This website was started by some UCSF geriatricians, is really effective for serving this purpose, and designed for this as well. So one of the things that you know, for any prognostic tool we should be aware of is just like how good it is at discriminating these outcomes. So, you know, we're pretty familiar with like a Chad's FAST score, or like TIMI score, Framingham Risk Index for, you know, cardiovascular events, for 10-year cardiovascular events. But I would just point out that essentially that the way these graphs work is that, you know, if you had a line that was drawn right down the middle here, that would be like the discrimination of your tool is essentially a coin flip, that it doesn't provide any special insight. And then a perfect tool where that, like, it predicts the outcomes of whatever you're looking at 100% of the time, then you'd have essentially the line move like that. And so most of our tools end up that we actually utilize fall somewhere in the middle, so in the 0.6 to 0.8 range. And this is kind of the range that are that the tools provided on eprognosis.org. Their C statistic, or their discrimination. So Um, Previous to a review that was written in 2011 to go over these tools, these things were all buried separately in individual journal articles. There was no way to navigate their specific use case, um, and determine what was the next best one. So these UCSF geriatricians said, what if we compile all these into like a very user friendly um, um, platform? And these are, specifically looking at community dwelling adults. Some of the the kind of the scoring tools that are provided. So and they all have their use cases. So the combined Lee-Schoenberg mortality index can provide prognostic information at the 4, 5, 10, and 14-year mark for community dwelling adults that are over 50. And these are pretty useful tools on the spectrum of predictive tools. This is kind of the best we see. For the Alex Lee Comprehensive Prognostic Tool for Mortality and Disability, the cool thing about this one is that for adults over 70, you can also get predictions on ADL disability and walking disability. They're not as accurate for those compared to mortality, but this is something in earnest that patients care about. They want to know about their ability to maintain their independence. There's a Deardroff mortality index, which is inclusive of specifically adults with dementia. And then and a 10-year international mortality index that looks at community dwelling adults that are outside the United States. Okay. And then there are also some tools that are available for patients that are currently residing in nursing homes. And so I think in utilizing these tools, I just highlight that we are not great at recognizing, a prognosis of under 6 months in non-oncologic patients. So it just highlight specifically in the cases of heart failure, COPD, and dementia, geriatric failure to thrive, cirrhosis, ESRD. These are the cases where we should be quite vigilant in using prognostic tools to see if patients could potentially qualify for a hospice referral. So one of the great things about the tools that are provided on this website is that from the homepage essentially you can access prognostic calculators, time to benefit, and cancer screening. And if you go to the time to benefit, essentially you could do a prognostic calculation on what their life expectancy is going to be, then utilize the time to benefit to essentially look at therapies being utilized or screening tools and make a determination on whether those should be continued to be utilized with your patient. And there's specific like data representation that comes with the cancer screening as well. And there's patient-facing educational materials that can go into greater detail and try to take some of this this data and provide a visual representation that's like more easily understood. This is kind of an excerpt from the pamphlet that can be downloaded from the website. But for example, what is the chance of having serious harms from a colonoscopy within the first 30 days? And they show this representation of 1,000 people and the chance of potential harm based on this. So I think in talking about screening and in making these decisions with patients, we end up in this territory of implied prognostication. It's not people can understand if we're, especially if we're appropriately giving them anticipatory guidance that that certain interventions can benefit people with a certain remaining life expectancy. And so it can enter this space of having a bigger discussion about prognosis. And I think having like a sense of what people want is important. And I think based on the research is that people, when they have more time to live, if their lifespan is longer, they might be less interested in their doctor's prognostication. But if they have potentially lower life expectancy, there's an increase in interest among older adults. And this has been, you know, the studies that have looked at this, they've been inclusive of people in other cultures as well. There's never been any like mode of being able to generalize, you know, for one culture. We talk a lot about cultural differences with regards to prognostic information and people not wanting to know and people wanting all the information. But ultimately, at the end of the day, this should be, you know, we should inquire individually with our patients to learn their individual preferences. But it's something that we should feel empowered to bring up because the data supports that we don't do it enough and that people do want to know. Okay. So in discussing like the risks and benefits of screening and then like kind of the implied prognostication therein, I think you know, providing anticipatory guidance for potential plans in the future to discontinue screening is important. I mean, you may not be the one to ultimately be, depending on how long you see a patient, you may not be the one to say at a future date, like, oh, we're going to stop. It might be reasonable to consider stop doing this screening going forward. But you could have at least begun that conversation that every time that we do a screening test, you know, it's worth mentioning that, like, you know, this is typically something that if we expect people to live another, you know, at least 10 years, then it's beneficial. But we consider stop screening in individuals if they're not expected to live that long. And I think, you know, our patients are going to have varied degrees of comfort with in preference about wanting to talk about this, and we can inquire with them. And if it needs to be simplified to saying that they want this communicated as this test is not recommended for you per our medical guidelines, or just simply the potential harms of this test outweigh the benefits, we can communicate in that regard. Now, but if patients seek a more direct discussion, you know, I think I was thinking about the language on this, and I think I would wonder what you guys think, but this test is very unlikely to provide information that would impact your life expectancy. Sounds better to me than, and you're unlikely to live long enough to benefit from this test. So I think, and then additionally, with having these discussions, using visual aids is helpful, as we talked about from the patient-facing materials. And then I would just say that, you know, these can lead to broader discussions of prognosis, and I think that there's, you know, in the literature, there was this litmus test of saying, like, you should be thinking about having goals of care and prognostic discussions with patients. You know, if you ask the question, would I be surprised if this patient died within the next year? And the answer to that question is no. So that's like a mental checkpoint to say, that maybe they need to start having these discussions. But even outside of that, having a framework for approaching these discussions, being able to, to step back and say, maybe we need to have another visit regarding this and talk about your preferences on how much we discuss this, understanding, getting on the same page with regards to their understanding of their own health. Share your perspective on what their long-term prognosis is based on the data that you have available, acknowledging that these things are just a tool and that they don't say how somebody is going to die. They don't specifically say that somebody is going to become disabled, but and then exploring key topics. If you're having a fuller discussion about this, about their goals, their fears and their worries, their sources of strength, the things that would be most important to them in terms of ongoing function, trade-offs in their care, like how much medical care they'd be willing to pursue and put up with if it afforded them more time, family awareness of goals, and then summarizing these things. And I think, proactively doing these things outside the setting of a context of like an acute hospitalization, again, it's always better, where people are not also balancing the distress of dealing with acute symptoms and being ill. So this is just going to be some cases, and I welcome anybody's input on this. I'd initially considered doing small groups and stuff, but I think we can just kind of read through these and see what you guys think. Okay. So our first case, we have a 69-year-old female with a history of COPD. She's on 2 liters of HOMO-2 with active smoking. She's down to 3 cigarettes per day. She has a history of a TIA, chronic back pain, and mobility restrictions with recent falls, prior stimulant use disorder, bipolar disorder, and she's presenting for routine follow-up care. She's had 3 hospitalizations in the last year for COPD exacerbations. She lives alone in a trailer park in Skagit Valley, and gets help from various people with the upkeep of her home. And she accepts Meals on Wheels because preparing her own food has become too exhausting. For mobility, she utilizes a standing walker or quad cane, depending on the distance she expects to walk. And she knows that she needs to rest if she walks quarter mile. And despite a remote history of a cervical fusion and limited ability to turn her head, she still drives 2 hours to clinic in a large truck. She's had no accidents that she's aware of. She still has the marbles she was born with and manages her IDLs. She has a lively social life and is very involved in a local faith-based recovery group where she takes a fulfilling mentorship role. In your prior conversations, she prefers straight shooting with regard to discussion with medical prognosis. And she often reminds you that her cancer screenings before you bring them up. She prefers detailed justification for care decisions, and is engaged in the details. Trust has been slow to build, and she remains unvaccinated for COVID, despite multiple discussions on the topic. She is due for colonoscopy and mammogram screening. So 69 years old, has quite significant, chronic disease history. Does anybody have thoughts, without like utilizing a prognostic tool, like just eyeballing this patient? Would you recommend colonoscopy and mammogram screening ongoing? You can just answer that to yourself.
Yeah, I don't think I would, Joe. Yeah.
Yeah.
Yeah. I mean, I'm not sure what the population data is on, being on home oxygen, with, being able to not cook food for herself, but I'd imagine, not great.
Yeah. Yeah. And this is like, and if we run her through like use the prognostic tools available for us on the ePrognosis website. I mean, this is the information that's provided. It clearly states that for her, more likely to inflict harm than to help, and that the number needed to screen is extremely high. That she's very likely to not live long enough to benefit from these screenings, and that there's a significant share of people that would that experience harm from this. So just to show the interface a little bit more and how these results show up, it will also provide you with discussion of benefits and harms that you can review with the patient. And I think that this language is pretty patient friendly.
Joe, I really appreciate you walking us through this, and like I'm sure that we can all think of patients on our panel that this is like super relevant for. So I know you had a couple other cases, but I also want to be mindful of the time if you kind of have closing thoughts for us to take home.
Yeah. Let's see. I just wanted to show, that these, specifically for prediction of mortality, you can end up with this life expectancy number that results, and this can ultimately provide you with a table where you can utilize that number to start thinking about, whether it's appropriate to liberalize an A1C goal for people, and or whether it's continuing to be beneficial for like more intensive blood pressure goal and so on. So this informs other care decisions beyond just cancer screening. And then, there's this case of kind of severe dementia, and I would just point out that there's also good prognostic tools for patients with dementia that can be utilized, and they can begin to help you to be able to approximate, would they be approaching potential like hospice referral eligibility? Because I don't feel like outside of having a tool available that I have a good sense of like how much how much longer these patients are going to live. So I feel like it's valuable. I think those were the last couple of things that I wanted to highlight about using this tool.
Awesome. Thank you so much. This definitely has like real take homes for our patients. Thank you to everyone who came to Academic Half Day this week, and we'll see y'all in 2 weeks.
Have a great Thanksgiving for those that are celebrating.